will discuss the development of pancreas and spleen, starting with the development of the pancreas. Now this pancreas is developing from the two endodermal pancreatic buds arising from the junction of foregut and midgut. So those buds are dorsal pancreatic bud and ventral pancreatic bud. So these diagrams are taken from your standard textbook. Now in next step, ventral bud arises in the inferior angle between the hepatic bud and duodenum. So you can see here. Now this portion is going to form, or this part or this bud is going to form the lower part of the head and uncinate process. The dorsal bud, this dorsal pancreatic bud is just arising from the dorsal aspect of the gut and is going to form the upper part of the head, neck, body and tail. What happens next to this? The duodenal loop falls to the right. As a result of this, the ventral bud comes to the point to the right and dorsal bud to the left. Now with differential growth of the wall of the gut, the attachment of the ventral bud, it also shift to the left, you can see. So with rotation, you can see they were lying opposite to each other. But once the fixation of the gut is happening and the differential growth of the gut is there, or duodenum portion is there, the attachment of the ventral bud also shift to the left. Now this pancreatic tissue, they've just formed from these two buds. They fuse with each other to form a single mass. Now later on, initially they have independent ducts, you can see here. Later on, a communication is formed between dorsal and pancreatic ducts. This is the anastomosis which is happening between these two ducts. So coming to the development of the ducts, that is accessory pancreatic duct or duct of Santorini is just a duct developing from the main dorsal duct. How? Which portion is contributing to this? That is duct of dorsal bud between anastomosis. So this is the anastomosis between dorsal and pancreatic bud and duodenum. So this point, that is between the anastomosis and the duodenum, this portion is going to form the duct of Santorini. It remains narrow. It opens into the duodenum at minor duodenal papilla. Now coming to the main pancreatic duct, or which is called as duct of Wirsung. So coming to the same diagram, initially that these two ducts, they were independent. Then the communication it is established between these two ducts. Then the main pancreatic duct is contributing by the dorsal pancreatic duct and ventral pancreatic duct. Now this ventral duct of ventral bud is going to form the proximal portion of the main duct, and duct of dorsal bud is going to form the distal part of the main duct. And in between these two portions, this communication is also contributing to the duct of Wirsung. So distal part of the duct is formed by dorsal pancreatic duct. Then proximal portion of this is just developing from the duct of ventral bud. So this is to be remembered, that the part of the duct between the communication and the duodenum of which part of the pancreas, that is developing from the dorsal bud. So this portion is going to form the duct of Santorini. And this main pancreatic duct or duct of Wirsung is opening into the duodenum at major duodenal papilla along with the bile duct. Now minor duodenal papilla is about 2 cm proximal to the major duodenal papilla. So about 2 cm distance is there in their openings. So this is the sequence of events which are happening. You can see how the rotation is happening of the tissue. Then next is fusion, it happens. The ducts, they fuse with each other, and later on this is the full formed pancreas with the different ducts. Now coming to the histological component of the pancreas, the secretory element of the pancreas is derived from the endoderm of pancreatic duct. By the proliferation of the primitive duct, acini are formed which lose their connection with the duct and then multiply. So the different ducts, that is duct of Santorini, duct of Risberg, they just basically divide and redivide, and the terminal portion, they become the acini and they get detached from the main duct system. So they just take the function of secretion. So secretory element of the pancreas is developed from that. And islets of Langerhans, they are developing from group of cells which are derived from the primitive duct system again. Some cells, they take the function, endocrine function. Some cells, they take the exocrine function of the pancreas. Now coming to the anomalies of the pancreas, these are the various anomalies, that is annular pancreas, divided pancreas, then accessory pancreatic tissue, then inversion of pancreatic duct. First we will discuss the anomaly, that is annular pancreas. In this, the pancreatic tissue completely surround the second part of the duodenum, causing its obstruction. You can see in this diagram. Basically, as the pancreas develop from two endodermal bud, we know this is the dorsal pancreatic bud, this is the ventral pancreatic bud. But what is happening next to it, that ventral pancreatic bud, it divides into two. So you can see this bifurcation of the ventral pancreatic bud, it happens, and they fail to fuse with each other. The two parts of the ventral bud, they grow. You can see both the parts, they grow and they migrate in opposite direction around the second part of the duodenum and form a collar of pancreatic tissue before it fuses with the dorsal pancreatic bud. So basically this annular pancreas is derived from which portion of the pancreas? That is from the ventral bud. So ventral bud, it become bifid, or it is divided into two portion. You can see in this diagram too. So it is dividing into two and closing or encircling the duodenum completely. So definitely, as it is surrounding the duodenum, so this pancreatic tissue can cause the obstruction of the duodenum. Now, clinical features of the annular pancreas will be: the vomiting may start a few hours after birth. If we will take the x-ray, we will see that the double bubble appearances is there. So this double bubble appearances is basically because of the associated duodenal stenosis, then indicate gas in stomach, dilated part of the duodenum proximal to the site of obstruction. So these are basically the things which just confirmation or clinical clue for the diagnosis of the annular pancreas. So early surgical intervention is needed to relieve the obstruction. The surgical procedure is duodenogegenostomy. So, but it is not the cutting the pancreatic collar. They just make they do the duodenogegenostomy to relieve the obstruction. Then come to the divided pancreas. So this is most common anomaly of pancreas. Dorsal and ventral bud of pancreas fail to fuse each other to form a single pancreatic tissue. Both the parts, they remain separate and drain separately through dorsal and ventral pancreatic ducts into the duodenum. We know it that initially the ducts, they were independent and later on the communication is established. So the communication is not established in divided pancreas. Most individuals with this condition remain without symptoms and complications. Both the tissues, they are doing their function independently. Then accessory pancreatic tissue, the small masses of pancreatic tissue are located at the falling sites, that is wall of duodenum, macus diverticulum, gallbladder, lower end of esophagus, wall of stomach. The ectopic pancreatic tissue may present with obstruction, bleeding, etc. Then inversion of the pancreatic duct. The main pancreatic duct is formed by the duct of dorsal pancreatic bud and open into minor duodenal papilla. You can see here. Normally beyond the communication, this part it become narrow, but in this case it is not like that. So drain most of the pancreatic tissue. The duct of ventral pancreatic bud develops poorly and opens into the major duodenal papilla. Or you can say that independently they are working, but that is duct of Santorini is not formed. So the majority of the tissue of the pancreas is drained by this pancreatic duct, which is derived from the duct of the dorsal bud. Coming to the development of the spleen, it is a vascular lymphoid organ, mesodermal in origin, starts developing during 5th week from a collection of mesenchymal cells in the mesogastrium, and some cells are contributed coelomic epithelium lining of mesogastrium. So coelomic epithelium is contributing, and it is just a collection of the mesenchymal cell in mesogastrium. So mesenchymal cells are basically they just form lymphoblast and other blood forming cells. Initially, the mesenchymal cells lying between the layers of the dorsal mesogastrium, they condense to form a number of small masses called as lobules of splenic tissue or spleniculi, which later fuse to form a single mesenchymal mass. We call it as splenic mass. The splenic notches which are seen in the, you can say, in a spleen, that is when it is completely formed, the splenic notches, they just show the remnant of grooves. The primordium tissue differentiate into number of trabecular cords and free cells between them. Hemopoietic function continues during fetal life and it regresses after the birth. With the development of the spleen in dorsal mesogastrium, it is divided. You can see this diagram. We have discussed this diagram a number of times. So this is the stomach. You can see this is the liver on the ventral side. This is the portion of ventral mesogastrium which is going to form the falciform ligament and coronary ligaments. This is the part of the mesogastrium, ventral mesogastrium, which is going to form the lesser omentum. So this is the dorsal part, this is the ventral part of ventral mesogastrium. Now similarly, with the appearance of the spleen, the dorsal mesogastrium is divided into two portions, that is ventral portion and dorsal portion. Now this ventral part of the mesogastrium is going to form the gastrosplenic ligament. So this is the gastrosplenic ligament, the part between the spleen and the kidney going to the posterior abdominal wall. This is known as the linorenal ligament. So spleen is lobulated in the fetus, but lobules, they just disappear after birth. Coming to the anomalies of spleen, so there may be accessory spleen. Accessory nodules of splenic tissue can be found at many sites such as hilum of spleen, gastrosplenic ligament, linorenal ligament, tail of pancreas, along the splenic artery and greater omentum rarely. So these are the sites where the accessory spleen can develop. The next anomaly which is related with spleen is the lobulated spleen. As we have discussed the development of the spleen, it is just developed from the collection of the mesenchymal cells. So definitely the persistence of fetal spleen, which is formed due to the fusion of number of small lobules of splenic tissue called spleniculi. So that is developing into lobulated spleen. So this is all about the spleen. So I hope you will like this lecture. So thank you very much.